Good afternoon, everyone. I find it's a very limited crowd here. Of course, ocular oncology is also a very niche specialty, and so there are many things we need to know about these ocular tumors in a regular practice, be it a general ophthalmology practice or a specialty practice. And that is what we are going to take you through. We have very renowned, good afternoon, sir. Welcome. Hi, Akshay. So we have very renowned clinicians, researchers who practices solely ocular oncology in their practice. So I welcome the esteemed speakers, Dr. Seema Das, Dr. Vikas Menon, Dr. Santosh G. Honavar, and our pathologist Kaustubh Mule. I hope he makes it. He's on the way. So, we will be covering the entire spectrum of tumors from conjunctiva to the lids to the orbit to the intraocular. Our first speaker is Dr. Seema Das, and she is the consultant oculoplasty, orbit, and ocular oncology, head of the department of Shroff's Charity Eye Hospital at Delhi. May I request you to take over the dais, Dr. Seema, to take us through ocular surface tumors. Over to you.
Thank you, Feroz. So I'll be talking about OSSN, the current protocols of treatment that we follow, and what are the new things. So OSSN we know has diverse morphology clinically, and the treatment modalities range from conservative topical chemotherapy, immunotherapy, and then going on to the destructive surgeries, ranging from enucleation, exenteration, and of course excision biopsy for the more advanced tumors. Histopathologically, we can classify them into intraepithelial disease, invasive OSSN, which is invading the sclera, and then going inside, being locally invasive, growing intraocularly, or going to the orbit, and then metastatic disease. So I'll just try to connect these two, connect the disease or the invasive pattern of the disease with the treatment modalities that we commonly use, and just kept it more case based. So this gentleman, elderly gentleman, was diagnosed in the cornea clinic as having an herpetic dendritic keratitis, as it looked like a stippled epithelial involvement which was running in a linear fashion in the inferior half of the cornea. But what is important to note is that he has this small nodular lesion which looks like a keratin plaque at the limbus. Another patient diagnosed as Salzmann's nodular degeneration because of this white nodule-like lesion involving the corneal epithelium. But if you see under slit lamp retroillumination, what is very apparent is that the lesion in the epithelium seems to be well demarcated with fimbriated edges. Yet another gentleman, he was seen in the clinics because he has initially consulted somewhere else where an applanation tonometry was done, and he came back following an epithelial defect post that, which was thought to be because of the applanation, which maybe was not done correctly. So when you stain, there is staining with fluorescein, but what we also see is that stippled involvement or appearance of the epithelium, which probably is because of the keratin which is there on the surface epithelium. So all these are variants of the corneal OSSN, corneal epithelial involvement. And the typical feature here is the fimbriated edge, finger-like projections. And if we see carefully under slit lamp, we will also be able to see the small blood vessels which are there inside the lesions. So for corneal epithelial involvement by OSSN or any surface OSSN which is still in the epithelium, ASOCT is now the investigation modality of choice, which we do for every patient before starting the patient on conservative management. So ASOCT has very specific features involving an abrupt hyperreflective thickened epithelium, which kind of, there is an, do we have a pointer here? Do you have a pointer? Yeah. So there is an abrupt transition from the normal epithelium going on into an hyperreflective and a thick epithelium, and we can clearly see the, here we can see the lesion is entirely confined within the epithelium and underlying basement membrane seems to be intact. So these are the lesions which are typical good candidates for topical immunotherapy or chemotherapy. If you want to confirm further, we can do a little bit of scraping from the epithelial lesion, do the GIMSA evaluation of the slides, and you can see the atypical cells, which is again further confirmatory. So intraepithelial disease like this, if we diagnose, topical therapy is the modality of choice. There are various modalities or various protocols which are followed for topical chemotherapy and immunotherapy. MMC used to be the drug of choice earlier, and generally the protocol which is followed is 0.04%, 4 times a day, 4 days a week for 4 weeks. But there are many other protocols which can be followed. Interferon came in between, showed a very good response without the side effects which are typical of mitomycin C. And now generally 5-FU have also been found to be a little more effective than interferon with a little lesser side effect profile than mitomycin C. This is one of the patients which is predominantly involvement of almost 10 clock hours of cornea, which cleared up significantly with just topical mitomycin C, leaving behind a clear cornea with not too much of scarring. The same gentleman that we see had the cornea totally cleared up after interferon. So we have to understand one thing, that before we start the patient of topical interferon, we have to ensure that it is an non-invasive disease, means the disease is confined to the epithelium, not breaching the basement membrane, unlike here where there seems to be some breach in the basement membrane and the disease seems to be going into the underlying stroma of the conjunctiva or to the corneal lamella. So if that is there, then it's a contraindication for topical therapy. Sometimes even in a lesion like this where there is too much of keratin on the surface and a little thick lesion, it might not be possible to see the underlying basement membrane on ASOCT. So if there is any doubt, it's better to go ahead with excision for this kind of lesion rather than starting on topical therapy. I'll skip the video. So these are usually the corneal variant of OSSN. There are a few other variants which can also be a little more aggressive. The atypical variants like a diffuse blepharoconjunctivitis, where there is involvement of the sclera with a lot of thinning. This was a pigmented OSSN in an HIV positive patients, and a nodular variant which tends to go more deeper than come more towards the surface. These are also typically seen more commonly in the xeroderma pigmentosum patients, other patients with immunocompromised state. This was a young patient with a corneal OSSN which was covering almost the whole of the cornea, which we can never be sure whether it's going into the stroma of the cornea or not. So these are the situations where you might have to do an pre-op UBM and might have to be prepared for a little more extensive surgical excision than just a simple excision of the lesion. So if required, we can go for a lamellar keratectomy or a sclerectomy for this patient. Generally, if 2/3 of either the sclera of the cornea seems to be involved in OSSN, then lamellar keratectomy or a sclerectomy can take care of the base of the lesion and ensure that we have a clear base. Patch graft is to be avoided mostly in this patient because if there is a recurrence beneath the graft, it's difficult to detect, then it might go unnoticed and go intraocularly. The same patient, we took help of the cornea colleagues. They did a lamellar keratectomy and he did have a clear cornea in the postoperative period. I will again skip this video. Another patient where a sclerectomy was done. And this is what is important, where you see the histopath, you can see the scleral lamella at the base of the lesion, which seems to be free of the tumor. So this tumor was excised in toto along with part of the scleral lamella. So invasive OSSN, surgical excision is the treatment modality of choice. Along with that, we always do cryotherapy to the margins, to the base, and we always ensure a base clearance. But there are some situations where the base might not be clear. Like in histopath, we can see there is scleral lamella. You have already done a sclerectomy, but there is tumor beyond that. So you have left behind some residual tumor, microscopic, after the excision also, and this patient needs to be treated with additional adjuvant therapy. Most commonly what is used is plug brachytherapy. This is one of the patient who was Dr. Anirban's patients. In fact, she was operated and the base was positive, but the residual tumor, we did a plug and she's doing pretty well on follow-up. Another patient, again on UBM, we can see there is some involvement of the sclera. So till the time she was waiting for surgery just to do a little bit of chemo reduction so that your surgery is a little less extensive. She was started on topical mitomycin C and she responded very well to topical MMC. So that's the time we thought, why go in for an excision? Just go ahead with a primary plaque, and a primary plaque was done for her. And I think it's more than 1 year follow-up now and she seems to be doing fine. So there are situations like this where there is too much of involvement of the sclera, more than 2/3, and here it's very clear invasion of intraocularly. We can see it on UBM going to the ciliary body area. CT also confirms the same, there is a breach. And these are the patients where you definitely have to go for an enucleation. So what are the signs that the tumor has gone inside the eye? There will be some anterior chamber inflammation. Gonioscopy will give you some clue. High intraocular pressure could be one of the indicators that this tumor might have gone intraocularly. So if you suspect in any OSSN patient that it might have gone intraocular, it's a good idea to look for these signs. Another patient where it was referred as a perforated corneal ulcer for evisceration, but if we see carefully, this is the residual area where there is keratin plaque, and this was probably the tumor involved the whole cornea and caused a corneal melt. So these situations where there is an intraocular invasion has to go for an extended enucleation, which is little more than what we do normally with a clear conjunctival margin. So what I mean is that when you normally do the enucleation, you do a peritomy 360 degree. Here your conjunctival incision should involve the whole area with a clear margin involving the tumor area. And then we proceed like a normal enucleation. This was the same patient. You can see the involved OSSN with the conjunctival margin, and then the eyeball is taken out along with that. If there is an orbital invasion, these patients have to go in for an exenteration, usually an anterior orbital exenteration. And rarely, OSSN is generally not a disease which is very invasive or kind of metastasized beyond the local areas. But sometimes this was a small tumor in the eye to begin with, not very big, but at presentation, this gentleman had an preauricular lymph node involvement, which was positive on FNAC. So possibly these are some of the variants which are more aggressive. Maybe the tumor biology plays a role here. And these patients, we don't have very good treatment modality available to cure, but there are now new targeted checkpoint inhibitors and other therapy available, some of which are now available in India, the PD-1 and the PD-L1, the CTL4 inhibitors, the pembrolizumab and the ipilimumab, the tongue twisters. So at least it can increase the lifespan for some of these patients, but it is expensive. Most of them are not able to afford it. So if there is a possibility, we can offer this to some of our patients. So just to conclude, careful ocular and systemic evaluation is very, very important whenever we are seeing a patient of OSSN. Not everybody is a candidate for topical therapy. Please select your patients very carefully, which are surgical and which are medical management cases. Imaging modalities like AIOC and UBM helps a lot. And histopath has to be seen very carefully to ensure that there is no residual disease. So thank you very much for your attention.
Thank you, Dr. Seema. Do we have any questions for Dr. Seema from the delegates? Anything regarding conjunctival tumors, need not be OSSN, and she manages the entire spectrum of conjunctival tumors. Anyone? Dr. Anirban, anything that you want to comment on your experience with conjunctival surface tumors? Right.
To know whether it is reached a placement template before we even think of topical chemotherapy is, I think, the most important point that she's made.
Right.
Apart from that, she shared some of the cases that we worked jointly, that there's been scleral invasion, and Mark is actually taking care of those patients, and we've been able to salvage those cells.
Right. So, Dr. Seema, I have one quick question for you. So, when we use interferon, I'm sure you use it in your practice, we also use intralesional. So, is there a particular set of patients where you would use a combined topical and intralesional, and in a set of patients where you would use only topical?
So generally, I tend to use intralesional. One is it's an extensive disease, or if there is a diffuse OSSN with some nodular component within it, or if you feel that the patient will not be able to come for a very regular follow-up, or the cold chain maintenance might not be very kind of reliable.
Right.
So those patients, instead of letting them put the drops, maybe an injection is something which might hasten the process of resolution, especially if there is a diffuse involvement with nodular areas. Simultaneously topically started, but in those nodular areas we can simultaneously inject also.
Okay.
So generally these are the set of patients where injection is given.
Okay. And what is your experience with 5FU now that everyone is like talking about 5FU?
So it is something in between in terms of efficacy. It's probably more efficacious, more faster resolution than interferon, little lesser than MMC.
Yeah.
But I think one or two patients we had bad experience with the corneal epithelium.
Right.
Stromal melt. There was one patient
stromal
who
melt.
Had stromal melt.
Okay.
So
and your dosage is
1%.
1%.
4 times a day for 1 week.
Yeah.
But there was one lady. Now she had some pre-existing corneal epithelial disease. There was disease in the other eye also, bad ocular surface. Now whether that predisposed her to that, but she had a stromal melt. So somehow she recovered, but there was a scarring of the cornea. post
Cornea,
that.
okay. Yeah.
Otherwise, it definitely is more faster resolution than the interferon. And the side effect profile, the ocular surface side effect profile is probably a little less than the MMC.
MMC, right? Yeah. So your first choice would be what?
Right now, our first choice is a 5FU.
5FU,
Yeah, but
okay.
we monitor the patients a little more closely now after that experience.
Okay.
If there is any epithelial disease, then generally we tend to
Is
stop
there a
it.
particular reason why you would choose 5FU as your first choice?
Interferon one is the cold chain. So that
The cold
sometimes-
chain,
yeah,
right?
cold chain,
Yeah,
especially
yeah.
we are in North India, so that part of the country 8 months of the year is sort of and the patient profile many a times the kind of patients which comes to
Poor
us, they
patient,
sometimes don't
right.
have any access to the cold chain at times,
Right.
and the distance.
Right.
So that's one of the reason.
Okay.
MMC, of course, the side effect profile is something which you don't want. So
Right.
that's the reason we have shifted as first line to 5FU.
Okay.
And then if there are any other reasons not to give 5FU, then ocular surface is already bad and all, then interferon.
Yeah.
MMC is the third.
Perfect. Dr. Santosh, what is your worst side effect that you have got with 5FU in your practice?
Yeah.
Which was refractory, non-healing. It took tarsorrhaphy to heal. So
Okay.
that's about it. Otherwise, it's
Okay.
a safe drug.
Okay.
And that was a patient who had severe dry eye as well. So we should select out patients where there is no ocular surface issue or corneal issue. Then it's safe. It's not as much as mitomycin.
Right. So one of the side effect that I have noticed with 5FU is canalicular inflammation, like a canaliculitis, and the patient started coming with tearing of watering, epiphora post 5FU, but then put on steroids, possibly the inflammation settled down and the patient was fine.
Any
Yeah.
stenosis?
No, post there was no stenosis, but on treatment the patient was having epiphora and stuff and severe pain when I did a probing. So that was causing a canaliculitis in that patient. Yeah, inflammatory canaliculitis. Put the patient on steroids and the patient recovered well. Yeah.
Blepharitis is again another thing.
Yes, blepharitis, especially in the corner, they get yes in the corner. Yeah, near the medial canthus they get it. Right. Yeah. Anything else? Okay. Yes, Dr. Senthil.
So we give, once the visible lesion is gone on rose Bengal staining also, we keep it on for about 4 to 6 weeks. So another month or so, just to ensure that there is nothing microscopic which is remaining. Usually 2 to, yeah.
Thank you, Dr. Seema. Dr. Santosh, are you ready to go next? Okay. So I will be going next on orbital tumors. So good afternoon. It's just an overview about the orbital tumors and approach and management. I have no financial disclosures and no conflict of interest. So basically, we all say that orbit is a Pandora's box and anything is possible in the orbit. Well, we see a lot of tumors. Sometimes the diagnosis is right there in front of you clinically as well as radiologically. But then sometimes there are, dicey situations and dilemmas in orbit as well. So basically, a clinical evaluation, imaging is so very important. Systemic evaluation is so important, especially when it's a neoplasia, which could be a malignancy, and appropriate management is taken care according to that. So depending upon the origin, we have primary tumors, we have secondary tumors, which can be arising from the adjacent in and around structures of the orbit, and metastatic tumors. Now, tissue of origin, we again classify into neural, vasculogenic, lymphoproliferative, lacrimal gland, histiocytic, bone, and cartilage. Now, a very broad classification, another, the third classification is depending upon the location. It could be intraconal, it could be extraconal, or it could be both intra and extraconal. And this is the list of tumors that we come across. Now, going on, we'll go from pediatric to few important tumors from pediatric to adults. So this was two children, almost the similar age group, 1.5 years of age, presenting with dystopia. This child has a superior dystopia, and this child has an esotropia, a medial dystopia. So both these children has a space-occupying lesion in the orbit. So any child, 1 year of age, 1.5 year of age, who comes with a proptosis, the first thing that you would think of, especially axial proptosis, but in this child there is an abaxial proptosis, but the imaging shows it's optic nerve glioma. And well, this child does have other systemic features like cafe au lait spots, etc., in the body. Now this child doesn't have that, and this is the tumor that is sitting in there, a large cystic tumor. So orbit teratoma is something that can present in a child. So in this child we would go for surgery and excision biopsy. But whereas in this child, obviously it's an optic nerve tumor, you don't go and excise it, and diagnosis is by imaging, clinical and imaging. So there are certain non-surgical approach that we use in these children, that is systemic chemotherapy. So this child underwent surgery where there is a complete excision of the tumor, and this child underwent systemic chemotherapy. So depending upon what tumor you're dealing with, if it's an well-defined tumor which is excisable, definitely it's in toto excision. Otherwise, certain tumors like this, systemic chemotherapy really helps. So just giving you an update. So this is an update in optic nerve glioma. There are times when optic nerve glioma is observed and not done anything. Well, it does progress, although it's a benign tumor. It does. This child came with bilateral optic nerve glioma. So if we don't treat it and stop the progression, it can actually grow from one eye to the eye, the worst eye to the better eye. The child's worst eye was the left eye, and the right eye was a seeing eye. So in order to stop the progression, definitely there has to be a treatment. So the child received vincristine and carboplatin, whereas MEK inhibitors is something which is very new, and even anti-VEGF bevacizumab is considered. So we don't want to land up in this situation. This child at 8 years of age presented with optic nerve glioma with a progression, and it does progress. So this was how the child came with. At this point, in fact, the intracranial part of optic nerve glioma was also progressing, but the parents were more concerned about the cosmesis in this child, where the eyeball has really bulged. And I would say this was one of the largest tumor that I have excised, so enucleation has to be done, and a implant and prosthesis was fitted. So whenever you see a child with optic nerve glioma, there are treatment options. Consider treatment for these patients. Now, dermoids is not only pediatric; it usually presents due to the sequestration of the embryonic epithelium between the orbital bones, and it's usually seen in the medial or the lateral portion, and it's very typical. There is no dilemma about the diagnosis. In fact, there are situations where it may be a deep dermoid, and it could be a dumbbell dermoid which is extending to the temporal fossa also. So imaging is very important to rule that out. And most importantly, now taking a decision whether you want to excise it when the child is small or just wait. Well, in our practice we would actually excise even if it's a smaller child, because there is a chance of rupture. If at all there is a trauma, there can be inflammation and pain and swelling in these children. So, and obviously if it's a smaller one, cosmetically it's much better. So I would go for a lid crease incision over here and take out that small dermoid from there. Now this is Dr. Rajni is here, and it's my favorite case, and she had referred this case to me. A 10-year-old girl, proptosis, diplopia, rapid progression. In fact, it looks like a subconjunctival hemorrhage with a trivial trauma that the mother gives. You can see severe hemorrhage in the conjunctiva as well. Her imaging, this is what it shows. It probably could be an inflammation or even a neoplasia. But what was very striking is this triradiate location of the tumor, and it's extending to the temporal fossa, intracranial extension, and it was sitting in the lateral. Well, it could, initially when it came, I prayed that it be an inflammation and abscess of the lateral rectus, which is extending to the edges and structures. But whenever we have a triradiate lesion, be it a pediatric patient or an adult patient, these are the things that you have to keep in mind. As far as neoplasia is concerned, neuroblastoma, PNET, sphenoid wing meningioma in adults, plasmacytoma in adults, leukemia in children, or even lymphoma. So we went ahead doing an incision biopsy, and it came out to be an Ewing sarcoma, PNET, in this child. Luckily, systemic involvement was not there after bone marrow biopsy and PET scan. She underwent a multimodal treatment with chemotherapy and radiotherapy, and she's probably doing well. Ma'am, is she coming to follow up with you? Yeah. No, not with you. Yeah. You saw her once. I think they're going at, yeah, I think she's doing well now. Yeah, it's been 4 years now. Thank you, ma'am, taking care of her. 11-year-old boy, history of fall, referred as a case of retrobulbar hemorrhage. In fact, to an orbital surgeon to probably drain the blood or something, and his vision is reduced. Well, it's just not the left eye. If you see here, even there is a puffiness of the right eye over here, and he looks very frail and weak, and there is, the swelling over the maxilla as well. So, well, when a child present with this kind of an ecchymotic proptosis, the first thing that goes in our mind as a clinician is a leukemia. So the first thing, we don't even go inside. The only thing that we do is basically do a peripheral blood smear. And if you see the imaging, you can see a lesion over here, and there is a lesion growing in the other eye also. So it was a granulocytic sarcoma, and it was AML non-M3, which was really bad prognosis, and the child died. Another thing with ecchymosis is metastatic neuroblastoma. This was a child who was referred from Bihar, treated for orbital cellulitis, rapidly progressing. This bulging happened in 10 days, and in the train journey that they had, 2.5 days, they say it was like really, really bad. All right. So, well, when we did the imaging, it was not looking like an orbital cellulitis. There is a space occupying lesion over here, a large one. Went ahead. So, in a child presenting with this kind of a lesion, obviously PNET is something that we would consider. Rhabdomyosarcoma is usually seen in the first decade. Slightly older child, a 3-month-old child, is very, very rare. But when I went inside, it was almost like a well-defined lesion. So I didn't do incision biopsy. It's so very important in rhabdomyosarcoma as a surgeon that you give maximum surgical clearance. If you can take out the entire thing, the prognosis is much better than leaving behind some lesion. It came out to be an rhabdomyosarcoma embryonal, as I told you, in the first decade of life. But there are extremes also. This was a 23-year-old, who was again referred from Yemen. And you can see this was how she presented. And January, her proptosis was very subtle. She was waiting for the visa. And by the time she reached me in April, it was this situation. It's a recent case. A large lesion. Well, when I didn't think it was rhabdomyosarcoma, because she was old. But then I went ahead, removed the entire lesion. She had a corneal perforation also even before she visited us. We couldn't salvage the eyeball and the vision. And then eyeball is still there, but vision is not salvageable. And this was a large tumor that we excised. But this is what I want to actually see. Rhabdomyosarcoma, if you really suspect, pull out the tumor entirely. And why would I say that? As you can see here, we group it. Group 1 with good prognosis is tumor completely removed. Okay. Now, group 3 is gross residual tumor. So it actually prognosticates what is the tumor status. So it's very, very important. And we have the multimodal treatment protocol. I'm not going into that. Now, going into adults, the most common tumors are the intracorneal lesions, as in this lady and this patient, where the vision had dropped, with optic disc edema into 6/16, both the patients. And you can see an intracorneal lesion. But, well, the lesions are different. This is my kind of yellowish in color. This is a schwannoma, and this is very, very reddish like a strawberry, and it was a cavernous hemangioma. So we excise it. But there are situations when it's present in the apex of the orbit. We usually don't take it out because that can compromise the visual compromise in these patients. So gamma knife radiotherapy is something that we would sort. This patient with a very subtle proptosis in the right eye, first thing that we do as clinician, for us, it's just not orbital evaluation. We also dilate all these patients with orbital space occupying lesion. And this is what we saw, the coleochoroidal shunt. Coleochoroidal shunt, proptosis, what would be the diagnosis? Meningioma, yeah. Optic nerve meningioma. All right. So we did an imaging, and you can see that there is thickening of the optic nerve. Now, meningioma has another nature also, which is called the sphenoid wing meningioma. So the optic nerve will be spared, but the sphenoid will be involved. There can be orbital lesion space occupying lesion laterally, and it goes to the intracranial aspect also. So this was a patient. So both the patients, the treatment is radiotherapy. That's what we do. We try to debulk. In optic nerve meningioma, we don't do any biopsy or excision, but in a sphenoid wing meningioma, we try to debulk. Sometimes if it's too large, we take the help of a neurosurgeon as well. And both of them got radiotherapy, a linear accelerator. Well, I'm just showing this patient for two reasons here, 52-year-old lady, because this was the first orbitotomy that I did when I was a fellow at LV Prasad. So it's my favorite patient. A large orbital, a space occupying lesion in the lacrimal gland. She had undergone a surgery elsewhere earlier where the diagnosis was not really confirmed. A large lesion, when orbital, lacrimal gland tumor, it has been a long standing. So malignancy was ruled out, probably a benign lesion, but we always want to take it out in toto. We don't want to take a biopsy of a pleomorphic adenoma and leave it there and then cause a malignancy later. Well, the entire tumor was taken in toto. My first case in my career, which started as a fellow, this came out to be a solitary fibrous tumor. Now there are vascular lesions. This is a lymphangioma over here, venolymphatic malformation. So venolymphatic malformation, we don't go and surgically excise it nowadays. The treatment is bleomycin. So this is a patient where I have extended my application of bleomycin apart from venolymphatic malformation to varices. So I do inject bleomycin in varix. This is a patient with Valsalva's where it is extending. I'm going to go quickly through. So this is how I inject bleomycin. There is a three-way valve. I aspirate the blood and then I inject through another port. So this is how we do the procedure. Well, so vascular lesions, this is a keratocavernous fistula, a low flow in this gentleman. So there is a newer classification. This was for the postgraduate student when we always talk about orbital vascular anomalies, ocular vascular anomalies, talk about ISSVA in your examination. I'm not going to, talk to you elaborately. Now, ocular adnexal lymphoma is a very important topic here because this is the most common orbital malignancy that we come through. It can be in the orbit, it can be in the muscle. As you can see here, there is multiple muscle involved in this patient. Bilaterally, it can be in the lacrimal gland. So this patient had a regional lymph node metastasis, no systemic metastasis. He underwent systemic chemotherapy. We do PET scan to rule out that. This patient had only ocular involvement. What I did for her was something very new. What I did her for the boom radiotherapy. Boom radiotherapy is a ultra low dose radiotherapy. So what we do, traditionally it is around 25,000 centigrade that we apply, but here it is like 400 plus 400, and that is what a very low dose. And also she received an intraorbital rituximab injection because it was CD20 positive. So this is the panel of IHC markers that we do for orbital lymphoma. It's just not telling that it's a lymphoma or a lymphoproliferative lesion. We need to typify it. There are so many markers that you do to find the commonest to the rarest. And so this is a 52-year-old gentleman who presented with this lesion. Initially, it was thought it could be a meningioma, a sphenoid wing meningioma. Even I thought so. He was, came for a second opinion. I went ahead doing a biopsy, and this came out to be a lacrimal gland adenoid cystic carcinoma. And why is that important? Because this is the most lethal and most treacherous malignancy of the orbit. We did publish recently my work with Dr. Santosh Unawa, my mentor. Seema was also part of this work, and we had spoken about the multimodal treatment protocol where we actually initially do neoadjuvant chemotherapy, consolidate the tumor, excise it, radiate it, and give adjuvant chemotherapy with improved survival and globe salvage. So orbital neoplasm and biopsy, last two slides. Non-surgical approach, yes, we have lesions where we approach non-surgically. Incision biopsy in those cases where you want diagnosis and excision when it's a well-defined lesion. There are situations where you don't even go inside. Like, when you're suspecting a granulocytic sarcoma in a child, it's just peripheral blood smear, gamma knife radiation, risky lesions in the apex, and stenting and coil embolization in vascular lesions. Yeah. Thank you very much. So let us not be scared about these lesions. If we can manage it well, please do manage it appropriately, and the patients are going to have a good outcome. Otherwise, refer it. Thank you so much. May I invite Dr. Santosh Unava, the teacher of all teachers, and he's very well known. I don't have to give an introduction. He's the one who has produced a lot of ocular oncologists in India and abroad. Over to you, sir. We're all trained from him, and we look upon to him in various aspects of ocular oncology. And thank you for being with us today. Over to you, sir. And he will be speaking on intraocular tumors.
Good afternoon. Thank you, Feroz, for putting together a very useful course. I'm surprised at the attendance.
Yes, I'm so happy. We started with few, but now it is filled. Thanks. That's the interest.
So I'll cover only two intraocular tumors, which are the most common: retinoblastoma, which is the most common malignant intraocular tumor in children, and melanoma, which is the most common primary malignant intraocular tumor in adults. In retinoblastoma, we have had a total turnaround from about 98% mortality just about 122 years ago. Now we have more than 98% survival. That kind of revolution has not happened in any other malignancy except retinoblastoma. We have prioritized the management goals in retinoblastoma. First goal is, of course, life salvage, and if that is possible, eye salvage, and if that is possible, maximize residual vision. In a small tumor where the tumor size is about 3 or 4 millimeter in diameter, 3 or 4 millimeter in thickness, there is no problem at all with eye salvage and life salvage. So we go on to maximize vision, and that can be done with focal therapy, where what we consider is less is more. That means that the minimal treatment that you do, minimally invasive treatment that you do, or minimally damaging treatment you do, that is better because you want to maximize vision. Cryotherapy has excellent success. You can see this a small tumor has been reduced to a flat scar with cryotherapy. But if you note carefully, the size of the scar is much larger than the tumor that you began with, because cryo is very heavy. It is triple freeze thaw cryotherapy, where the tumor is frozen thrice and thawed thrice, and the area that is affected by cryotherapy is much larger than just the tumor. It's heavy cryotherapy. And also, if the tumor were to be somewhere around the equator, it may cause distortion of the macula fovea, cause epiretinal membrane, cause vitreous hemorrhage, and also rhegmatogenous retinal detachment because of atrophic retinal holes. So cryo is done, but it is not the preferred modality of treatment currently. Photocoagulation is also performed in many centers, but the problem with photocoagulation is that you have to surround the tumor with 2 rows of large diameter laser burns, resulting in a much larger scar than the tumor that you began with. For example, if this is a tumor, then we have produced this larger scar, and you can see the blood vessel that is passing through that area is blocked. So the patient will have small blood vessel occlusion, and if the tumor were to be lying in juxtapapillary location, then you would end up with a large arcuate visual field defect, right? So photocoagulation is performed, but it is risky in visually crucial location. You can do photocoagulation definitely in the periphery, but when it comes to the posterior pole, it is not something that you would want to do. So the current standard of care for small tumors is thermotherapy. When we use diode laser thermotherapy using indirect ophthalmoscope delivery system, which is 1800 micron in spot size, you can reach anywhere in the retina. Location is not the barrier at all. Right from the ora serrata to the posterior pole, anywhere can be reached, and the size of the spot is so large that you can cover the entire tumor within a matter of about 3 to 5 minutes. So it's a slow laser where the goal is not photocoagulation but induction of tumor cell apoptosis by increasing intratumoral temperature to about 45 to 60 degrees centigrade. Now, what happens with TTT is that you do it right on top of the tumor, so the scar is very crisp. Scar is never larger than the tumor that you began with. And the blood vessel that passed through this tumor, and you can see that that's a very small, subtle scar, and the blood vessels are classically patent. So that's the advantage that you have with TTT over photocoagulation. It's a magnified view of the same. You can see even the smallest blood vessels have been spared with this technique, and they don't get scarred at all. What's new in TTT is we use the synergistic combination of TTT with indocyanine green. You can't call it exactly photodynamic therapy, but there's a synergy between ICG and the wavelength of TTT that you use. So it can be used advantageously in patients who have had a recurrence or had a tumor with very little pigment background. You can see this is a flat white scar. On top of that, this patient has unfortunately recurred, and that can be treated with ICG enhanced TTT that has about 80 to 90% success. So you don't have to resort to plaque brachytherapy or chemotherapy here. these recurrences can safely be treated with ICG enhanced TTT. Plaque brachytherapy is extremely good, but again, the scar size is never smaller than the tumor that you began with. It's generally used for tumors which are about 16 millimeter in diameter and maximum 8 millimeter in thickness if you use iodine, and about 6 millimeter in thickness if you use ruthenium. It's very useful technique. We have a notch plaque now which can actually circumvent the optic disc, and the disc generally remains healthy. This is a patient who was chemo resistant, who was treated with plaque brachytherapy. You can see that the tumor was overhanging the optic disc, the temporal edge. You can see nice optic disc without any optic atrophy following plaque brachytherapy. So that kind of advantage you can get. And recent advances that we have Indian plaque, which is made by BARC, which is less than 5% of the imported plaque. In chemotherapy, we have enjoyed the benefits of intravenous chemotherapy. It's a method of reducing the tumor size, the thickness, as well as the diameter, so that we can apply more focused, less damaging therapeutic measures. The advantages of chemotherapy is that the scar, again, is much smaller than the tumor that you began with. There are two tumors here, one there, and you can see the scar size is much smaller than the tumor that you began with. It's very advantageous in a posterior polar lesion because macular fovea gets exposed very early in the course of treatment, thus maximizing vision. The second advantage of intravenous chemotherapy is that the tumor always hangs on to its source of blood supply. It always regresses towards its source of blood supply. For posterior polar locations, the blood supply is generally from supratemporal or infratemporal arcade or supranasal or infranasal arcade. Now you can see that this patient has a tumor which is deriving supply from the supratemporal arcade. At the end of one cycle, you can see initially the tumor was abutting the fovea. After one cycle, tumor has left the fovea slightly and is regressed towards its source of blood supply. After 6 cycles, the tumor has completely left the fovea macula and has regressed towards the supratemporal arcade. So you can maximize vision by giving chemotherapy in a patient who has a posterior polar location. Third advantage, of course, retinal detachment goes away very early in the course of treatment. It does remain the standard of care in India, but what has happened in the last 15-20 years is that there are newer forms of chemotherapy that have come into vogue, such as intraarterial chemotherapy, periocular chemotherapy, and intraocular chemotherapy. Now, for intraarterial chemotherapy, we can use either melphalan, which is a single drug, or in combination with topotecan and carboplatin. An interventional neuroradiologist gets us access to the ophthalmic artery, after which we take over and inject these drugs right into the ophthalmic artery under visualization and monitoring. So this can be done very effectively, and this is used to treat tumors of group D or group E more successfully. Up to group C, there is no difference in prognosis in eye salvage and tumor regression between IAC and IVC. But when it is a group D or a group E tumor, there's an advantage of at least 10 to 15% in terms of eye salvage and tumor regression with intraarterial chemotherapy. You can see nice regression with intraarterial chemotherapy. Large tumor with a lot of vitreous seeds completely regress following 3 cycles of intraarterial chemotherapy. Even recurrences can be treated with intraarterial chemotherapy. The vitreous seeds were the major bugbear in the management of retinoblastoma. Now there is a new classification for intraocular seeds. We don't call them vitreous seeds anymore. We call them intraocular seeds. The classic vitreous seeds, which you always knew about. Then there are prehyaloid, subhyaloid, epiretinal, intraretinal, and subretinal seeds, which is guided by OCT. And intracameral seeds have been further categorized as depository, which walk through the zonules and come into the anterior chamber, or infiltrative, which come contiguously infiltrating the ciliary body, peripheral iris, and the anterior chamber angle. There's a difference in prognosis between these type of seeds. How exactly do we treat vitreous seeds? After the initial tumor has regressed or the retinal tumor has nearly totally regressed, we bring in intravitreal injection. That's a safety enhanced intravitreal injection. Initially, we started using melphalan. Melphalan is very effective. You can see this bunch of vitreous seeds gone after a couple of injections of melphalan. But melphalan is a weekly protocol. So it's logistically difficult to call these children every week and give them injection because of geographic and travel issues. And also, after a few patients, we started noticing a unique complication in pigmented eyes, such as ours, Asian Indians, retinal pigment epithelial atrophy, which can actually reduce their vision. They also started developing cataract and uveitis, which is not seen in Caucasian eyes. So we shifted over to a much gentler drug, topotecan, which is highly bioavailable, but at the same time does not have the complications that melphalan produces. This is lazy 3-weekly protocol, not a 1-weekly injection. So we can easily schedule these patients without logistic hassles. These are some of the examples of intravitreal topotecan. We need about 3 to 6 injections to get rid of these cells. They either become calcified or completely disappear. So initially, when we published it, there was 100% success. That was a selected group of patients. Now, with more and more patients being recruited because of the diverse spectrum of patients, we have about 85 to 90% success with topotecan, including severe cases. Intraocular chemotherapy, the extending indications are anterior chamber seeds. The depository seeds go away with either intravitreal or intracameral chemotherapy. This does not cause corneal endothelial toxicity clinically. Of course, we have to do specular microscopy when these children grow up. This is a patient where there is a infiltrative anterior chamber seeding. You can see that the peripheral iris and the angle are infiltrated. There is a ciliary body tumor as well peeping through this pupil. For this component, this was the only eye of this patient. Other eyes were already enucleated. We did plaque brachytherapy for the ciliary body component. For the anterior chamber seeds, we did intravitreal melphalan and intravitreal topotecan. So with all this treatment, the patient finally regressed. So there is an advantage in using a combination of treatment in desperate or difficult situations. One more advantage that we have noted is that these epiretinal seeds or subretinal seeds also start going away with intravitreal topotecan. So we don't have to do extensive laser TTT to all these areas. Simply give intravitreal injection and these seeds start disappearing. About enucleation, we know that we need a long optic nerve stump, longer the better. 15 to 20 millimeter is ideal. But at the same time, we have to kind of orient our pathologists to identify high risk factors, histopathological high risk factors, which are iris and ciliary body invasion and choroidal invasion of more than 3 millimeter in diameter or 3 millimeter in thickness, and optic nerve invasion beyond the lamina cribrosa. In those patients, if we don't give adjuvant therapy, then the chance of mortality is about 25%. If we give adjuvant treatment, that can be reduced to about 4 to 5%, thus giving a life salvage benefit of 20% straight away. So we have to identify histopathological risk factors strictly by protocol by using not just the central pupillar optic calate but also lateral calate and bread loafing, and then go on to give adjuvant treatment. In orbital RB earlier, orbital exentration was considered the treatment of choice, but that has about 70% mortality. So if it's primary orbital RB identified clinically or radiologically, we go ahead with neoadjuvant chemotherapy, which is often high dose chemotherapy. After the orbital component regresses, we go ahead with a safe enucleation and then deliver stereotactic radiation to the orbit and finally top it up with adjuvant chemotherapy. It's a year-long treatment with about 95% life salvage. It can be used even for patients who have an optic nerve invasion. You can see this thick and optic nerve has been reduced to normal caliber, now safe for enucleation, or anterior intracranial extension to the cavernous sinus. All that's left now is at the superior orbital fissure, which is amenable to stereotactic radiation. Cosmesis is a definite bonus in these children. We don't have to do exentration anymore. So despite giving radiation, you can see that the cosmesis has been maintained and the child does not have even a mild contracted socket. One more child where you can see how thick the lid was. Even the lid was infiltrated with a tumor, and after completion of multimodal treatment, the lid has nicely settled down to be a flat, normally anatomical lid, and the prosthesis is well maintained. In melanoma, we have, depending on the location of the tumor, in iris melanoma, we can simply do a iridectomy. If it's a tumor which is as small as this, you can do a sector iridectomy and iridoplasty. Otherwise, if it's extending slightly into the angle, you can do iridocyclectomy. But for patients of this sort, where there is a larger tumor, you can do plaque brachytherapy. Now, plaque doesn't make the tumor completely disappear. It produces a stable scar. So this patient, you can see from this point on, has reduced to this, and from there on it will remain stable. All you need to do is observe annually. Of course, cataract is a complication of plaque brachytherapy. If it's an anteriorly located tumor, we can safely operate for cataract after about 3 years. But for larger iris melanomas, we have to do enucleation. Ciliary body melanoma, again, local resection, plaque brachytherapy, and enucleation are the treatment of choice. This was a patient where there was a larger ciliary body melanoma with a iris pigment epithelial cyst. So this was actually a masquerade. If you were to simply look at this and diagnose it, it's a iris pigment epithelial cyst. But hidden behind it was a ciliary body melanoma. We did plaque brachytherapy, and you can see that the tumor dimension has reduced after 6 months, and it is likely to remain so. This was a patient who
So sorry to
Yeah.
wrapping it up.
Sure.
Yeah,
This was a patient with iris ciliary body melanoma with hyphema treated with plaque brachytherapy. Larger tumor like this need to be enucleated. In choroidal melanoma, we go by the COMS protocol, but then we don't do this anymore. Observation of small melanoma is not to be done anymore. We are waiting too long. Every millimeter adds to the risk of metastasis. For small melanomas, we treat with transpupillary thermotherapy, whereas for medium-sized melanoma, we use plaque brachytherapy. It does have a complication in terms of radiation retinopathy that can be to a certain extent reduced by giving anti-VEGF injections at the time of removal of plaque for every 3 months for a year. These are some of the examples of plaque brachytherapy with reasonably good success. Proton beam is available in India, but it is very expensive. You don't use it often. Partial lamellar sclerouvectomy can also be performed in tumors which are like this, a tall tumor with a small base where plaque is not possible. We can do excision, otherwise enucleation. So I think I can end there. Thank you so much.
Thank you very much, sir. May I request Dr. Vikas Menon to take us through the eyelid tumors? Thank you so much, sir, for a excellent overview. Yeah.
Thank you, Dr. Fairuz, for having me part of this course. So, I'll be talking about surgical protocols for eyelid tumors. And so these are some of the benign tumors that we see, or benign lesions as you may call them in your OPD routinely. So what happens is, if you have a patient like this, then nothing serious. So you just need to do a shave excision or excise them superficially, and you don't have to worry about any deeper invasion or anything, because you know these are benign. But of course, send the material for histopathology. That is very imperative to avoid any surprises. But we know that malignant tumors are also not very rare in the eyelids, and every few cases of benign lesions consistently you will get one or two surprises where it will turn out to be malignant tumors, and these can be commonly in our country sebaceous gland carcinoma, basal cell carcinoma, or less frequently squamous cell carcinoma, and melanomas. Lymphomas and vascular tumors are usually secondary to the orbital involvement, where they involve the lid secondarily, so you have to treat them differently as per an orbital tumor. Now, our aim of treatment when we talk about malignant tumors of the eyelid is, number one, is to try to remove the tumor completely and not leave any residue. Second is to cause minimum disfigurement or functional disturbance with our treatment. And number three is, whatever treatment we choose to do, it should not somehow compromise the overall survival of the patient, and that should always be kept in mind, that no point trying to give cosmesis to a patient while putting the life at risk. So you have to look at the whole patient and not just the eye. So one common doubt that arises in our minds when we see a tumor of the eyelid is whether to first perform an incisional biopsy or to completely excise the lesion, which we call as excisional biopsy. Incisional biopsy is the term that we use when we take out a small sample of the tumor, and excisional is when we remove the entire tumor in the first go. So incisional biopsy is usually required when diagnosis is doubtful clinically, or when we have a large tumor and where we are planning a major excision or reconstruction. There also it's better to confirm the diagnosis one before subjecting the patient to a large excision or large surgery. And if you are planning to, it's a more extensive disease where you have to actually remove the eyeball or cause some destructive surgery like enucleation or exenteration, then of course medical legally also it is important that you have confirmation of the pathology report with you before you proceed with such a destructive surgery. Now, if you have a small lesion like this, which is like 3 by 2 millimeters or so, it's easier to completely remove it rather than taking a tissue of it and subjecting it the tumor to unnecessary trauma. So go around the lesion and excise it completely. Normally, whatever the protocol we follow is 4 millimeters on either side of the tumor, and what is important is to have negative margins. Negative margins in any malignancy, margins are the most important. It's a general principle that is followed all over the body wherever cancer treatment is done, that you should have negative margins, which ensures that you've taken out the tumor completely and not left behind any microscopic residue. So if you have a small lesion, it's easier. You can simply excise the lesion, send the margins for histopathology, and depending upon where you are working, if you have access to frozen section, then you may plan your reconstruction the same day, But if as in majority of our places where people operate on lid tumors and frozen section facility is not available, there is no harm in waiting for the second stage or the reconstruction. You can counsel the patient preoperatively, but do send separate margins and wait for the histopathologist to confirm that everything is negative, and then plan your closure of the defect. So it's just a picture showing a pentagon excision for a small lid tumor that we usually perform. And once you have the margins negative, then you can do a direct closure as per routine normal 3-layered closure of the lid that we follow. In a slightly larger lesion where possibly you would have to excise a little bit of larger extent of the eyelid, you will need to rely on your knowledge of eyelid reconstruction and use some of the eyelid reconstruction techniques to form the eyelid after your excision. In this particular case, Hughes flap has been done. Tarsoconjunctival flap has been taken from the upper eyelid, as you can see, and that has been used as posterior lamella, and skin from the lower eyelid has been advanced to form the anterior lamella. But what if the lesion is something like this? Another thing is always evert the eyelid in case of, even if you feel that there is a small bump or a small mass, always evert the eyelid, and then that time you may get the complete picture. So here you have a more diffuse sebaceous gland carcinoma, which also has a pagetoid component. By pagetoid component, we mean that it's a specific form of sebaceous gland carcinoma which may have skip areas, which may have involvement of the conjunctiva diffusely as well. So here your protocol changes slightly. Now another 75-year-old lady came with a chronic blepharoconjunctivitis type picture, been on antibiotics and steroid ointments and everything for a long time. And if you look at the lid margin carefully, see all the lid margin meibomian orifices were gone, and there is diffuse thickening of the eyelid margin. All the eyelashes are gone, which are all the telltale signs of a malignancy. And incisional biopsy helps in these cases before you plan a major surgery to confirm your diagnosis. And once you have the diagnosis of a sebaceous gland carcinoma, and particularly the pagetoid variant, as in this case, then you have to go in for a reconstruction, complete excision. So here the complete excision of the tumor was done. And what is more important here is to note this picture, that you see the tumor has been excised and all these margins are kept separately and marked on the filter paper. All the markings are done, and then you have to draw a similar diagram on your pathology requisition form also, and then you send the samples in completion with the main tumor along with the separate margins, which may be 1 to 2 millimeters, and those are to be sent separately. But when you have a diagnosis of pagetoid sebaceous gland carcinoma, then another thing that you need to add to your treatment is conjunctival map biopsy. This is the one indication where you need to perform this. So what happens is, as I mentioned, these tumors may have skip areas and multiple areas of involvement on the conjunctival surface. So to identify those areas, what we do is we take out small 2 to 3 millimeter round tissue biopsies from multiple sites on the ocular surface, as you can see in this picture, and then you draw the whole surface on a piece of filter paper, put those sample tissue bits on the specific areas, number them, mark them, and send them properly to the pathologist, so that the pathologist, when he gives you the report, he will give you a complete report, that is the main tumor, the nature of the tumor. Then he will comment upon the margins, whether they were positive or negative. And then thirdly, when he gives you report of the conjunctival map biopsy, by number he will give you the detailed report of all the samples that you've sent as map biopsy. It is a painful process for the pathologist, but it is very much important for the patient's proper management, because these if you have positivity in your conjunctival map biopsy, then that changes your protocol. Then if it is it's a localized kind of an involvement of conjunctiva, let's say in one fornix, then you can go and advance your excision, and if all the other areas are negative, then you have to advance your excision a little bit. But if a lot of areas, like recently we had a patient where almost 13 or 14 sites were positive, and then in such a patient there is no point going for any conservative treatment. You know, it's a advanced disease, so a patient had to be subjected to orbital exenteration only. Imaging has a limited role in eyelid tumors. You usually perform it when you have a tumor which is near the canthi. So if it's a medial canthal tumor or a lateral canthal tumor, you want to know if there is any deeper extension into the orbit, then you perform an MRI, which is the preferred modality. Uh, and if you see a slight extension, anterior extension into the orbit, nowadays we have the option of neoadjuvant chemotherapy also for sebaceous gland carcinomas, which can reduce the size of the tumor, and then you can make your surgery less invasive and less complicated. So you can just excise. This is one example. This is Dr. Anirban Bhaduri. Is a patient. Uh, a patient presenting with a large sebaceous gland carcinoma of the lower eyelid. This is post 3 cycles, and you can see how nicely the tumor has regressed in size, and at this stage only a small lump was left which could be excised rather than having to go for a larger surgery and possibly even exenteration at the presentation stage. But if a patient presents late and there is already a massive orbital involvement, then we don't have any option but to subject the patient to orbital exenteration, because saving life is more important ultimately. Fortunately, what we are modified our techniques from the earlier techniques of exenteration is we do a lid sparing exenteration, and it's very much easy and possible to give them a good prosthesis to have them lead a normal life. But what if you have an even more extensive disease like this? It's a basal cell carcinoma which is going even beyond the borders of the orbit. Or this patient came with multifocal type of basal cell carcinoma going much beyond the orbit. So what is the option here? In these cases, one of the options is to perform a large surgery and you have to team up with a facial or a head and neck oncosurgeon or a facial plastic surgeon as well, do an exenteration and also excise all the involved areas, and subsequently you have to give radiotherapy to these patients. The other option is vismodegib, which is a very expensive treatment and the patient has to take the treatment lifelong, but that is one option for these multifocal extensive basal cell carcinomas. Imiquimod is a local treatment for very small superficial type of basal cell carcinomas. This is an ointment, and that this can be used to reduce the size of the lesions. Squamous cell carcinoma, we don't have anything really very good so far, but there are some EGFR inhibitors being investigated. Hopefully, we'll have something in the next few years. Another point before, without talking about which the management would be incomplete of eyelid tumors, is lymph nodes. So, lymph node involvement from eyelid malignancies can range from about 1.3% to 40% maximum in melanomas. So, you have to be very careful and never ignore the lymph nodes. And whenever you see a patient of eyelid malignancies, always palpate the lymph nodes. And if there is any palpable lymph node, then go for a proper CT or MRI imaging of the neck, and that will show you the exact lymph nodes which are involved. And these are a few patients who presented with enlarged preauricular submental lymph node. Another patient presented with a preauricular lymph node. In these cases, if you leave the lymph node which is positive behind while treating the eyelid tumor aggressively, it makes no sense, because again the patient's life is still at risk. So you are treating the patient partly. So you have to work with a neck surgeon, get the lymph nodes also removed, and get the whole area treated with adjuvant radiotherapy also. For melanomas, there is one option of sentinel node biopsy, but the infrastructure and all the facilities required are not easily available. So, and also it's not a foolproof technique. So, not very important, I would say. More important is to identify the nodes clinically at least, and do a routine imaging, CT or MRI, and then if there is any enlarged lymph node, just get it removed and get it treated with radiotherapy. So, to conclude, the important thing for eyelid malignancies is to identify early, as for any cancer, and excise completely. Get your margins cleared by the pathologist before you start your reconstruction, and evaluate lymph nodes. Do not ignore them, and use adjuvant treatment like radiotherapy or chemo wherever it is required. So if you just follow these few things and you keep these few things in mind, it will make your life and your patient's life much better. Thank you.
Thank you so much, Dr. Vikas. So the next session is by Dr. Ramesh Murthy. So I have requested an extra time because I have someone really special here today, Dr. Jyotirmay Biswas. He's going to tell us in the next 3 minutes some very important tip in pathology, and it's my honor that he attended this instruction course on a special request he's just presenting. Since Dr. Ramesh Murthy and the team is not here, I thought we'll just go away. Over to you, sir. Just a quick 3 minutes. Over to you, sir. Presentation, please. And then we are done. Presentation, please.
Okay. I'll take 3 minutes only. This is a case presentation. Very interesting case. 26-year-old female, history of swelling in the left eye for 1.5 months, marked dimness of vision, 7 days. Referred by local ophthalmologist as a squamous cell carcinoma of the conjunctiva. Right eye was normal, and left eye had light perception, inaccurate projections, multiple club KPs, and large mass lesion over the superior limbus. And this is the mass lesion. What is your diagnosis? There is a small lesions on the temporal part of the bulbar conjunctiva also. And was squamous cell carcinoma of the conjunctiva was the clinical diagnosis. He had a history of, I'd like to summarize that, HIV infection and treated with pulmonary TB, and was anti-HIV drugs was given. Developed swelling in the conjunctiva after that. ELISA for HIV was positive, CD4 count 233 cells. ESR was 125 millimeter first hour. Superior mediastinal widening was there, and CT scan showed diffuse thickening of the wall of the orbit, enlarged preauricular and submandibular lymph node. Now, what is your diagnosis? Enlarged preauricular submandibular lymph node, conjunctival mass.
Lymphoma?
No lymphoma. Conjunctival mass excision was done under local anesthesia, and you'd be surprised the patient had chronic granulomatous inflammation with giant cell, and there is many more giant cells with caseation necrosis. You can see the caseation necrosis, and acid pus bacilli was positive. On the top of it, there's a mass lesion was deficient, the wall was deficient, patch graft was given, and MTB was positive for the specimen A and B. PCR for Mycobacterium tuberculosis was positive. So this was a conjunctival tuberculoma mimicking squamous cell carcinoma of the conjunctiva. And this is a post-op photograph. Conjunctival ocular lesion in HIV is mainly posterior segment, choroiditis, multiple choroidal nodule, reactive tuberculoma, but no case of conjunctival tuberculoma has been described in ocular lesion in HIV positive patient. This was published in American Journal of Ophthalmology. Thank you very much.
Thank you so very much, sir, for having a great conclusion to this. Thank you so much. Thank you, everyone.